I am a physical therapist that has a clinic where, like, most people have failed everything. I treat the chronic pain world. So people that have failed like all kinds of things, right? And including especially physical therapy. I added hip capsula contractures and how they can cause all this referred pain, and it doesn't show up on x-rays and MRIs, and these people are kind of falling through the cracks. Don't need their VMO to activate. That they need is to get that kneecap back into alignment, so then they can do those exercises if you want them to, but they don't need that to during the course of their rehab. Okay. Today I had a guy that spent tens of thousands of dollars and had his spine fused, and they wanted to go in again. And I used my SI evaluation and my sacral evaluation, and I opened up his SI joints, and I realigned his sacrum, and boom, pain was gone. Hey everybody, what's up? Physical therapist, Dr. Whelton, coming to you from just outside the beautiful Tampa Bay area. If you are new to following me, I am a physical therapist that has a clinic where, like, most people have failed everything. I treat the chronic pain world. So people that have failed like all kinds of things, right? And including especially physical therapy. And I've learned to get exceptional results within that patient population, as seen in my peer-reviewed publications that I publish protocols that I use for these conditions. And I've been teaching for the better part of a decade now, and people all over the world have been using it, and I've been reposting their amazement, the results that they're getting, so it makes me happy. Okay, so big announcement, drum roll. So I published 4 papers. I published root cause of SI joint dysfunction, root cause of sacral torsion shear, anterior sacral tilt. I've published root cause of plantar fasciitis, and I published posterior impingement syndrome with all kinds of other protocols in that paper. Now, I am going to publish a couple other things, but I did not want to sit there and do study after study after study. It's really not how my brain works. I just like to treat, and I like to just tell people, like, the results I'm getting, and try this, try that, whatever. But in the medical field, you got to publish things, right? But I didn't want to do like all these orthopedic conditions and try to collect patient data. Some of these things I don't even see that much. Just over the years, I figured out, this works for me or that works for me or whatever. So what I did is I emailed the journal formerly known as the Journal of Practical Pain Management, where most of my publications are, and asked them if I could just add clinical guidance for more conditions. So as of yesterday, okay, you can go to my website, wheltonmethods.com, go to publications, click my journal articles, my root cause journal articles, and look up what I wrote. So it's basically, I added on and I gave all these other conditions and how I treat it, and protocols to use to help you. Okay. So I'm trying to remember off the top of my head, but so in my plantar fasciitis paper, I added metatarsalgia. I added, with the protocol, I added lateral ankle impingement. For my SI paper, I added more about SI. The longer I do this, and it's basically most of the patients I see in here is failed SI. I've failed everything SI type patients. And I've learned to troubleshoot these people over the years. So I added more insight into that. So I updated it, basically. And I also added a whole couple paragraphs, I guess, on sciatica. I added trochanteric bursitis for the protocol. I added patellofemoral syndrome in there. And then what else did I add? I added, I think it was my sacral paper, I added lumbar hyperlordosis, excuse me. And then I added, what did I add on that paper? I added lumbar hyperlordosis. I added hip capsula contractures and how they can cause all this referred pain, and it doesn't show up on x-rays and MRIs, and these people are kind of falling through the cracks. So you should go and reprint those out, okay, and pin it right in your office, okay? And that is my clinical guidance with protocols on how to treat these issues, Okay. And if you liked my SI paper, if you liked my plantar fasciitis paper and protocols, if you liked, all these other papers I published, sacral torsion shear, all that stuff, then this is the same thing. So this is the same type of protocols that work for me extremely effectively. And so they're free. Go ahead, use them. Anyways, so today actually we are going to talk about patellofemoral syndrome. Okay, so I have been a physical therapist for 20 years, and I probably, that I can remember, I would say in the last, I believe that protocol that I just published for patellofemoral syndrome that you could read on wheltonmethods.com, I believe that I published, I've probably been using that 15 years, maybe more. And I generally don't have issues with patellofemoral syndrome patients. I have one lady right now that has chondromalacia, which is a different game because she's got arthritis. But just to the general tracking issue for patellofemoral syndrome, I generally don't have any issues in my career helping these people that I can remember. And I published it for free. It's right there in one of those papers. You got to read them. Okay. Now, patellofemoral syndrome, we all know, is a tracking issue of the knee, right? So you have your femoral groove, you have your patella, and it typically tracks superiorly in the groove if the rectus femoris is tight, and or laterally if the IT band is tight. Okay. Now, over the years, I see people in here, shockingly actually, that have patellofemoral syndrome that have tried other things, including physical therapy. And I'm like, well, what do they do with you? And they tell me that they're having me do squats, they're having me do lunges, they're having me do terminal knee extensions, locking out the patella inside the femoral groove. If you think about what you're doing, I would never do that with a patient, ever do that with a patient. Because think through what's happening at the joint, right? So you got the patella that sits right in the femoral groove, but it's not sitting in the femoral groove properly. It's tracking superiorly for the rec fem tightness, and it's tracking laterally for the IT band, right? Tightness. So you have a patella that is shearing on the bone. And then when you do lunges, when you do squats, when you do terminal knee stairs, stuff like that, terminal knee extensions, step downs, you are firing their quad and you are taking that thing and shearing it bone on bone, okay? And when you do that, you are going to increase that person's symptoms. To me, I would never do that. And some of my patients come and they say, oh, my PT had me do that. I'm like, stop that immediately. And it doesn't make any biomechanical sense to do it that way. Okay, now, my protocol that I just published, it is free. Go to Whelton Methods and download my papers again, reread them. I updated them, okay, with other conditions in there, okay? And patellofemoral syndrome is one of them. Is, like usual with me, is extraordinarily simple. It is stretching the IT band and stretching the rec fem, and that's it. So when a patient comes in here and they have patellofemoral syndrome, like, I'm not worried about it at all. I just give them these 2 stretches and I set a watch, like in like 5 weeks, they're better. Like I generally don't. Now, if they have chondromalacia, that's a problem. Okay, that can be a problem depending on how bad it is. Like this patient I have now, she's just bone on bone in her knee. So she's been stretching it, but she's still having pain, peripatellar pain. Okay, that's a different game. But for a straight up tracking issue, I generally don't have issues with that protocol. So I recommend that you use that, okay? And I also recommend that you stop strengthening people's quads. Stop strengthening people's quads, okay? Because they're maltracking. There's a maltracking going on. And you're shearing bone on bone when you are firing the quad patella tendon, okay? Don't need their VMO to activate. That they need is to get that kneecap back into alignment, so then they can do those exercises if you want them to, but they don't need that to during the course of their rehab. Okay, and it's common sense. If you just think of what I just said, if a joint is tracking out of alignment and you're going to do things that shear the joint, Like, no, 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 no. You know, like, let's just get that back into the joint kinematics are proper, and then you can do whatever you want with the patient. You know what I'm saying? In fact, you'll create something like chondromalacia by doing something like that. You know, you're just shearing cartilage, right? You know? So anyways, let me show you what I do for patellofemoral syndrome. Annette, can you come here for a second? All right. All right. Can you lay on your side, face this way for me, please? Okay, so the Ober's test. Huge fan of the Ober's test. The Ober's test is a great test. In early on in my career, I feel like I didn't do it correctly until I started to engage and really think through what I was doing with the Ober's test. And so I would just go like this, and then, you know, their leg would drop, and I'd be like, oh, it's negative. But you got to catch it, right? You know, you got to bring it up and around and make sure the IT band catches. So you got to bring it way up and around and make sure it hangs, okay? And then the other thing is if you notice I have my hand right here. So a lot of people, they let the pelvis just drop like that, and that will affect the position of the knee. The knee will drop lower, right? So I make sure the pelvis is still in neutral, okay? So with this hand, and I make sure it catches, I bring it up and around, okay? And then I let it hang. Now, a positive test, it should go 10 degrees below parallel, okay? So parallel 10 degrees, so she's about there, okay? Maybe a little tight with her. But when that's tight, then you get tracking laterally with the IT band as it goes into the patellofemoral complex there, okay? And you get maltracking, all right? And then, so that's how I do the Ober's test, okay? So make sure you stabilize the pelvis here, okay? And to make sure it stays in neutral, and then make sure it catches, okay? Not this. Don't just do that, okay? Because then they'll just drop, okay? But make sure it come around and catch, and then let it hang, okay? Now, with the modified Thomas test I use for rec fem tightness, okay? So, Annette, can you come here for a second, please? Put your butt right here, swing your legs on the end, okay? Hope everybody, I have to turn this camera. Okay, so for the modified Thomas test, let's say I'm testing this leg here, her left leg. Go ahead and hug this knee to your chest. Hug it, hug it. Okay, now lay back, all the way back. Okay, now what you're doing is you're watching for this leg right here. Now, a negative test is greater than 90 degrees, but I find most people can't even get to that. So when I see it like 60 degrees, something like that, you know, like out to here, you know, with the knee, then I start to think that it could be, you know, it could be that rectus femoris is the problem. Now, one thing that you can't do, okay, the mistake people make with the modified Thomas test, and I used to make it, is that if you put, I tell them to put their butt on the very end of the table, because if she was any farther back, when she dropped back like that and laid back, the table would have forced her calf into extension and then threw off your test, and you wouldn't have known it. Okay, so make sure they're all the way at the end, and make sure that the knee is truly at the crux, right, of the table, okay, at the very end of the table. All right, now you can also check for IT band tightness, although I don't think it's as reliable as the Ober's test, but the person will go out like that. They'll have, if they have a tight IT band, then their leg will AB duct, okay, slightly, and that gives you an indication, but then I always follow it up with the Ober's test, okay? Thanks, Anna. Now, all of that being said, okay, so all of this being said about how to diagnose and treat patellofemoral syndrome, which I just published, I'll go to my papers on my website, wheltonmethods.com, it's free, okay, which I just published it. All of that being said, you can sit here and you can try to deduce, well, is it the IT band? Is it the rec fem that's the problem? Is it this? Is it? But years ago, just like my SI protocol is bilateral, like I would get to the end of the rehab of stretching someone's IT band because they had a positive Ober's test, and I didn't think they had a positive modified Thomas test. And then I would realize they still had patellofemoral syndrome, and I was like, oh my gosh, I missed it. You know, so then I have to do another 4 or 5 weeks of stretching their rectus femoris muscle, and it's like, why don't I just stretch both? You know, so as a prophylaxis, right? So what I did was create a protocol, which I published just now. and it's just 2 stretches, okay? And I usually find it takes about 5 weeks. I think I wrote that in the paper. It takes about, if the patient does it, 2 to 3 times a day. And it is, I mean, it's something that, like with my SI protocol that I published as well, with my SI protocol, I used to do, like, people ask me, why did you do this bilateral? My patient only has it on one side. And I said, because I would rehab the person and they would say that they had pain, from unilateral SI joint dysfunction, right? But then I get to the end of the rehab and they'd be like, yeah, no, I got this pain over here now, but they couldn't feel it because the brain only interprets the most painful area, right? So I was like, come on, man, so we'd have to do the whole rehab on the other side, right? And then I was like, well, why don't I just do bilaterally, as a prophylaxis, just to make sure that this person does not have bilateral SI joint dysfunction, and I just wasn't seeing it type thing, okay? So when it comes to patellofemoral syndrome, I stretch the IT band, and I stretch the rec fem, and I do not do anything else. I do not strengthen the VMO. I do not believe that has anything to do with this. You can do it after, once it's back in alignment, but if you do it during and you have a maltracking, you are shearing that person's patella against the femur. Nobody would argue that. That's what you're doing. You're shearing it, okay? And that's why these people come in here and they tell me, I went to physical therapy and they gave me that, but my knee flared up. Well, they were shearing it. When I asked them what they were doing lunges, they were doing squats, they were doing, step downs on a step type thing, and they were just shearing it, okay? So I do not do that. Like usual with me, things are simple, what's interesting is my kids have this great AAU track coach. His name is BB Roberts. And he's got this program where I played sports my whole life. I didn't even think this was possible. And he does this speed camp thing, okay? And where he takes kids over the course of about 7 to 8 weeks, and he dropped all 3 of my kids' 60-meter dash almost a full second, to over a full second in 7 to 8 weeks. And I'm sitting there and I'm like, wow, that's amazing. Like I played sports, high school. I got a scholarship to play in college. I've been around it my whole life. I didn't even know that was possible. But when I first saw what he was doing in this speed camp, it was extraordinarily simple. And at first I was like, this is too simple. I'm like, it's just so simplistic, And then it took me a second and I'm like, yeah, but that's what people say about me, is that everything I say is too simple. It can't be true. There's no way that can be true. I've heard it for years, right? But then, like, I publish it for everybody to do for free, and people start to realize, yeah, no, that is actually true. You didn't need all the fluff, right? And this particular guy, he's an intuitive. As soon as I met him, I realized just the way that his mind worked that he was an intuitive. And intuitives tend to filter. We filter things. We like, you don't need this, you don't need that, you don't need that. That's fluff, 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 fluff. And you read exactly what you need, which is why my biggest complaint about the medical field is it's so complex. People make this so complex, like SI joint dysfunction is an industry and they have all kinds of courses and treatments. But like, I published a paper with people that have failed, 12 patients that have failed like all kinds of things. And I gave them 4 exercises and they got better, and it was caused by an upslip and or outflare in my paper. You can read it. And this guy was like that. So anyways, my point in saying this is that a lot of this stuff is fluff. You don't need it. And in fact, it can hurt the patient, like in a video I did recently about bridges. Doing bridges with an SI joint dysfunction patient, which usually they hurt in extension. Think about what you're doing. You are locking out, you're putting them into lumbar extension. And when you put a person into lumbar extension, they have pain, right? But bridges put you into lumbar extension. So I will never do bridges with my patients with mechanical back pain, which I find in my clinic and in the papers I publish is the majority of the patients I see in here. And just today I had a guy that spent tens of thousands of dollars and had his spine fused. And they wanted to go in again. And I used my SI evaluation and my sacral evaluation, and I opened up his SI joints and I realigned his sacrum, and boom, pain was gone. and they wanted to do another surgery on him. And it was this SI joint. They weren't going to do SI joint surgery. They were going to fuse more levels of his spine. So anyways, I recommend you please go to my website. It is free, wheltonmethods.com, and get my papers and reread them. I updated them with new conditions, okay, with simple protocols, okay, that will help you in your clinic. And this is the stuff that I do in here. And you know, a lot of these conditions I'm not worried about when they walk through the door. Okay. And I love to hear it. When I used to teach live, I would see repeat. I'm teaching live again soon, but I would see clinicians and I would ask them, hey, how are you doing with my protocols for plantar fasciitis, for this, for that? They're like, not worried about that, And I was like, SI joint, not worried about it. They would literally tell me, yeah, I don't worry about somebody with that condition or this condition coming through my door now. So it just helps them take the stress out of it, by using those protocols. They're just like, they're not worried. They're not worried about the clinical part anymore, Okay, so I am teaching live now, okay? I am doing a model where I am going to teach you in a live online format. So there'll be consistent teachings every month, okay? And Q&A, okay? So we'll talk, okay? I can't wait to talk to you guys. We'll talk, and then also you'll get discounts on my courses, and my goal is to get people to get diagnostically on point, and then treatment wise on point. And we'll go over it, and also you can bring difficult cases into the platform. It's a community and on Zoom, and we can go over it together, and I'll help guide it, but we can go over it together and ask questions and troubleshoot and figure out what is going on with that patient, and we can establish a plan of care and go through the treatment course. So we make sure that this particular patient that you have, is not only got my eyes, the therapist's eyes, but like whoever else is in the group, eyes on you. We'll even be doing one-on-one mentoring live to help people improve diagnostically and treatment-wise, okay? So, and then I also have my group already that I've been, I think since like 2022, like 1 to 2 videos a month that I've been putting out, which is like new. I'm an innovator. So when I tried to figure out what I should do I'm always coming up with things. My mind never stops. I'm always coming up with new things. And I was always having to redo my courses to add things. But then I'm like, wait a minute. Why don't I just make a group? And so like every month I put something out, generally that I don't teach on the general internet, the open internet. It's a private group, and you can join it and ask questions. And then there will be a place where we can live meet and ask questions and go over things. So anyways, I'm super excited about it because I haven't taught live in years since COVID. I haven't taught live, so I haven't really interacted with you all, but I'm excited to meet you guys. I loved teaching live. I love talking to you all, and I learned so much. I'm so curious that I would ask questions all the time, like what are you having trouble with, and because then I can come up with ways to help. I like to problem solve, so that's my passion. In fact, when I'm not solving, like people talk about retiring, I'm never retiring. What I can't. I watched my dad try to do it, and he had a job in 10 months after 35 years. So I can't. I watched Norm Shealy before he died, publish a study on 99% reduction in drug addiction symptoms with a gamma PEMF on his head at 88 years old. And I'm like, that's the way I'm going out. So I will never retire. I love to solve problems. I love to help people. And that's my passion. That's my goal. And I can't wait to work with you all and bring it. Bring whatever problems you're having in your clinic, and bring whatever problems you're having with your patient, and let's do it. I'm game. Give me the hardest cases you got. I'm game, and I can't wait to help guide everybody on that. So you can sign up on my website, wheltonmethods.com, and we're creating a community, and we are going to be excellent clinicians. That's my goal. All of us. Okay. There is, I've said this before, I was teaching in a state, and there was a COO at my course of a major corporation. Think large chain. And I had so many questions for this guy. And I said, what is your success rates in these clinics that you have? He said 50% quit. And then of that, 50% get better. And I'm not that good at math, but I'm sitting there and I'm like, 25%. So 50% quit because they didn't think it was worth coming. And then of that, only 50% are getting better. I'm like, whoa, bro. I'm like, wow, we have a problem here. I don't think that's the general average, but anyways, we're going to get that. I got a guy in Luxembourg that openly states he's at 99% of his patients are getting better now after taking my courses. Openly state. He puts on his website that 9 out of 10 people experience immediate relief. So his name is Jeffrey John. He is a phenomenal therapist in Luxembourg. And I'm sure there's more out there. I just haven't met you, but I can't wait to meet you. Anyways, that's that. Go to my website, wheltonmethods.com. I updated my protocols and I added new ones. Okay, so print it out, give it to all your colleagues. It is free. Email it to them, send it to them, put it in your school group. If you're on Facebook, students, here's a guide for you. It's so confusing being a therapist. And some people that jump from health, they go to outpatient, they don't know what to do, and they're like, I don't know what to do. Like, I published it, it's free. Use it as a guide. This is how I treat these conditions. And I think if anything like me, you'll see success that I published in those papers. So other than that, I love you all. Peace. Stay curious. Curiosity, I'm telling you, is a game changer.